one of my favorite topics, geriatrics.
Everyone's favorite. All right, thank you. So this is probably, I think, the hardest lecture to give right before lunch, because for most of us, we see a ton of it, but it's really not very glamorous compared to the penetrating talk that we had earlier. So I just want to kind of go over the highlights of what's most important about taking care of a geriatric trauma patient. And all of you in this room know, whether you're an EMS or you're in the emergency room or you're a physician, there's more and more and more geriatric patients that we're all taking care of. And I think that's great that people are living longer, but it really puts a strain on our abilities as medical professionals to take care of them, because their physiology is out of whack, their anatomy is not the same, and even the littlest thing can really cause someone to have a major problem. And when you think about how many people are we talking about, first of all, the definition. So I don't want to offend anybody. This is a national definition. If you're over the age of 65, you are considered geriatric. And that population is increasing. We're up to 54 million people as of 2020. And a large portion of that population is going to end up either in your EMS rig or in our emergency department in the coming days, weeks, months, years. And when we're taking care of these people, it's extremely hard to really triage them. How do you know that somebody that fell off the curb on the way home from their Coumadin clinic actually needs to go to Fairview Hospital, or whether that person can just walk it off? It creates a major problem. Who do we activate as a trauma? Who gets the entire resources of a trauma system? Who are you going to take to your local ER, or who are you going to leave your catchment area to go to a trauma center to take care of? Really difficult questions, and I don't actually have the answers to them, because we're constantly working on our trauma triage criteria at Fairview to try and decide who needs us and who doesn't. And of course, from an EMS perspective, that's even harder. Who are you going to actually take to an emergency department that fell? Who needs to go to a trauma center? And that really is a big problem when we talk about geriatrics and geriatric trauma. So when you talk about the etiology of what happens to an older person that is involved in a traumatic event, overwhelmingly 74% of them are involved in a fall. And a fall, by definition, can literally be anything that from I tripped over my cat, I couldn't see where I was going and I fell over, I was on the toilet and I slipped off, to I fell down a flight of stairs, I fell off the roof putting my Christmas lights on. Like, that fall means everything. And while that seems like a huge range, the same injuries that I see in the person that tripped over the curb are the same injuries that I see in somebody that fell off a roof. And it just depends on how fragile that person is, and we'll talk about that in a second. Motor vehicle crashes only account for about 12% of geriatric trauma, and then pedestrians about the same amount, actually. And then penetrating trauma and other traumas are certainly much less common in the geriatric population. Every second, an older adult falls. So during the 20 minutes or so that I give this talk, there could potentially be hundreds of patients on their way to the emergency department after falling. And every day, an older person may be involved in a motor vehicle crash, and that has enormous consequences on our older adults. So again, to make everybody feel really great before we go off for lunch, I want to talk about what's going to happen to all of us as we age. But particularly, I want to think about it from the trauma perspective and what that means when we're trying to take care of folks or when we're trying to prevent them from having a problem. So as we all age, we're suffering from neuronal loss. We're starting to degenerate our cochlear, which means we can't hear anymore. We're starting to lose some of our spinal cord neurons, which means that we can't react as quickly. Now, the one thing that's a bonus to aging is that because our brains are shrinking, which sounds awful, but because our brains are shrinking, if we happen to hit our heads and bleed into our skull, we are less likely to suffer major catastrophic problems as a result of that. However, we are increasing our risk of having delirium because we have less brain matter. We're more likely to have psychosis or problems if we get admitted to the hospital. We can't tell where we are in space as well anymore, which is where you get these stories of, I was just walking somewhere and I fell over. We kind of lose our ability to have proprioception, and we have a markedly increased risk of fall in that circumstance. From a respiratory perspective, and this will be important later when we talk about rib fractures, we're decreasing our lung elasticity. Our chest walls are becoming much more rigid to the point where very small impacts can cause massive amounts of rib fractures. We have an increased VQ mismatch, and we can't cough as well anymore as we get older. So what does this mean? Increased risk of pneumonia, more likely to have rib fractures, harder for those rib fractures to get fixed, much higher mortality when you have chest wall trauma in an elderly patient, much more likely to end up on a ventilator. All of those things play a role because we don't have the same ability to react to trauma in the chest. From a cardiovascular system, certainly there's a much higher risk of developing AFib as we get older. This is a big reason why most of our trauma patients are on blood thinners when you go to pick them up, which of course is not a great thing from a trauma perspective to be on a blood thinner. There's increased dilation of the aorta. Their maximum heart rate is reduced to start with. They have no elasticity. Their blood vessels, if you hit them, they're hard, they'll break, they'll bleed. So as a result for that, what does that mean for us clinically? Well, it means they're going to have bigger bruises if they fall on things. It means they're at increased risk of rupturing those major blood vessels, increased risks of having problems, and of course, a lot of people are going to come in with heart rate problems, whether it's AFib, whether it's VTAC or VFib. All of these things are going to happen because their heart's not working as well as it used to. When you talk about the renal system, we're going to lose some of our nephrons. We're going to have an increased risk of having problems, increased risk of acute renal failure in the immediate post-trauma period, and then higher risks of constipation. So good news right before lunch as well. Okay, so frailty. Now, for those of you that are EMS and those of you that are the nurses taking the call from EMS in the emergency department, this is something that means a lot to me. There's a big difference between the 65-year-old who was playing golf and drank too much and sort of fell over, and the old lady in her wheelchair who falls out of her wheelchair, even if they're the same age. So it's not about age in geriatrics so much as it's about frailty. How frail is somebody? And there's a ton of different scoring systems. I've tried, I think, 2 or 3 in our progress notes at Fairview to try and decide whether someone's frail. Most of it has to do with medical frailty. Are they on blood thinners? Are they immunosuppressed? How bad's their ejection fraction of their heart? How much osteoporosis are we talking about? But I don't want anybody to memorize a frail scale, especially not an EMS person. But what I want you to do is be able to look at somebody and think, that person's frail. And you all know what that person looks like, right? It's the lady in the front of my talk. If you're bringing someone into me that's fallen, and you use the word frail when you give your assessment, I have a frail 85-year-old. And then that's put in the trauma pager, there's a frail 85-year-old coming in that just fell. That means something to me. That means that person is way more likely to be injured, no matter what mechanism you say. They're way more likely to be admitted, maybe even to the ICU. They're way more likely to have broken things. I have to be way more on my A game. So if I can tell you anything today, when you deal with geriatric patients, the one thing I would say is really consider frailty. And it's an eyeball thing, admittedly. Like, I'm not giving you a scoring system or anything. But when you see somebody that's frail, and you all know what I'm talking about, right? Please say that in your report. I'm bringing you a frail 65-year-old. Totally changes the game for me in terms of what I'm thinking about when I go see that patient. And of course, I'm going to see them too, but whether or not we activate it as a trauma, whether or not we get blood to the bedside, all of that makes a difference if you use the word frail. And of course, with frailty, what we're saying is that their response to stress is horrible. If you're not frail, and you fall, you can respond to stress, you can move on, you may not even need to go to the hospital. But if you're frail, you can't respond to that stress. And so as a result, you're going to have more broken things, more hemodynamic derangements, just overall problems. All right, so let's talk about this first case study. And I know we don't have ways that you can actually answer these questions, but I want to go through this a little bit. So this is pretty typical. A 97-year-old female presents to the ER. She tripped over her cat. She's fully anticoagulated for a stroke that happened 20 some odd years ago, and she's complaining of chest pain. Her heart rate's 60, her blood pressure is way higher than it should be, and she's satting fine on 2 liters of nasal cannula. So if you're the EMS team that's run up to her nursing home to pick her up, what are we going to do with this? Should we go to the level 1 trauma center immediately, even if you have to leave your county to do so? Are we going to forget about the C-collar because, she just tripped over her cat? We don't necessarily need to worry about a C-collar. Should we give her TXA immediately because she's anticoagulated? Or should we not do any of these things? And I'm going to go through each one a little bit because it's not a straightforward answer, obviously. So you don't necessarily have to go to the level 1 trauma center. I'm going to advocate that if you have a trauma center in your catchment area that's relatively close by, even if it's a level 3 or a level 2, you should think about it. And the reason is couplefold. One, I'm assuming at 97 she's probably frail. With the anticoagulation, she's more likely to bleed from whatever it is she hit when she tripped over the cat. Both of those things a trauma center would be helpful for. But the other thing is this chest pain, right? Is it she has rib fractures because she hit the table on the way down? Or was she actually having a heart attack when she tripped over the cat? And in elderly patients, the amount of medical issues that are going on in addition to the traumatic issues are significant. And you really need to have both teams available to take care of a patient in a hospital. You need to have the availability of medical docs that can help us with the stroke, that can help us with the cardiac event that may have caused her to fall, that can help us with the derangements that are going to happen from the electrolytes because her nephrons don't work anymore. And then you need a trauma person who can deal with the injuries. So I would advocate, if it's possible, a trauma center is a great idea. Now, here's the second thing. She just tripped over her cat. Can't we just leave her at the nursing home? I would say no. And the hard sign for me on this is the anticoagulation. We actually activate anticoagulate patients as a level 2 trauma right off the bat just because they're anticoagulated. Doesn't matter what the mechanism is, they're getting activated. And it's because they're more likely to have bled from whatever it is that they hit. So I would advocate, if you're the EMS staff called to whatever nursing home or whatever shopping center or whatever home where someone's in the bathroom, and they fell and they're on a blood thinner, you should take them to the hospital because they need to be checked out to make sure they're still not actively bleeding. And this is what sort of creates that, oh my gosh, we have thousands of patients now, because there's a lot of people on blood thinners, a lot of people on blood thinners. And certainly when I work them up, not all of them are going to have a problem. So it feels like an overutilization of resources, to be sure. However, those ones that do have a problem, they have a real problem. And it's very hard to tell when you're in the field, or even when I initially see someone in the trauma bay, whether they're one of those people that have a real problem or not. Okay, the C-collar. So definitely older folks, particularly frail older folks, if they fall and hit their head at all, they are much more likely to actually have a C-spine injury. We've moved away from C-collars in Cuyahoga County for penetrating trauma, which is totally appropriate. But I would advocate that for geriatric patients, you should consider putting the C-collar on. TXA may or may not be useful, probably not in this case, unless you know that she's bleeding. And then, of course, we're not going to do none of these. All right, so who do I activate? Who goes to a trauma center? What are we going to do with these folks that fall? So if we under-triage, meaning we say, they're fine, we increase mortality by a lot. So what most of us do, including us at Fairview, is we over-triage. We are more aggressive about calling stuff. It leads to a fair amount of patients that we see. It's frustrating for my partners and for the residents for sure. fair amount of people that we see that really have nothing wrong with them and probably didn't need me to come running down to see them. But we just don't know, and it's really difficult to get that triage just right, so we tend to over-triage in geriatric patients. For sure, people that you should be taking to a trauma center, for sure. GCS less than 13, more than one body region injured, long bone fractures, a fall from any height with a known or suspected TBI, a pedestrian that was struck. I mean, a geriatric patient, especially a frail geriatric patient that was hit by a car, they just need to go to a trauma center. And consider it with anticoagulants or any significant medical comorbidities. All right, so in the trauma bay, what's different for us when we're in the emergency department? Normal vital signs may not be normal. Most of these folks are on beta blockers, particularly if they're also on an anticoagulant, so tachycardia means basically nothing. We are extremely aggressive with imaging. This is a national recommendation. I always get pushback from radiology saying these are way too many scans, they're really normal, why are we doing all this? Doesn't anybody do a physical exam? Even the ER doc sometimes will say this to me, listen, I did a physical exam, there's no reason they need to be pan scanned. But the problem is that we miss things on the older folks and they go downhill really fast and you don't have enough time to react if you miss it. We monitor, we assess them early, we keep them overnight. At our facility, if you are anticoagulated, you're spending the night in the hospital, period, end of discussion, even if there's nothing wrong with you. And geriatric patients have very, very little reserve. So let's talk about head injuries. So extremely common in geriatric patients, even from very minor things. You know, I bonked my head on the edge of the couch. I rolled out of bed while I was trying to go to the bathroom and I hit my head on the dresser. Doesn't matter, they still, especially if they're anticoagulated, will end up with head bleeds. Fortunately, because their brains are smaller and there's more space between the brain tissue and the skull, they're less likely to end up with a massive problem, but still definitely need to be treated. What you often see with these, or what I often see, is somebody fell, like in the nursing home, for example. Everybody thought they were okay. Then they start falling again and again and again. It's usually on the third fall that they end up coming to the hospital. And at that point, of course, they've got a subdural and they've had one for several days. And it was the subdural that was making them fall over and over and over again. So trying to catch this stuff early and treat it certainly prevents secondary injury. The increase of bleeding goes up by 15% if they're anticoagulated. So again, these blood thinners, the cardiologists love them. My brother-in-law is a blood thinner person. He's a cardiologist. We have a fight every Thanksgiving about this. He thinks blood thinners are amazing. I obviously think they're awful. So somewhere in between is probably where we all need to live. But a lot of people are on blood thinners. Be aware of it. It changes things for us in trauma. If you can, you should correct coagulopathy as soon as possible. It makes a big difference for their long-term outcomes. But actually, you don't have to repeat a head CT if an anticoagulated patient has an initially normal head CT. We do still monitor them, though, for neurologic change and only repeat the head CT if there's neurologic differences. Okay, cervical spine, we talked about this before. Extremely high incidence of cervical spine injury, especially high cervical fractures like the odontoid, because of the way the head's sitting on the spine. In elderly folks, if you fall and hit your head, very high risk of a cervical spine injury. And these can be life-changing for geriatric folks, not because they, become paralyzed or anything like that, but if you ask an older person to wear a C-collar for 6 to 8 weeks, a lot of them can't swallow with that on. So then they can't eat. So then they have to go to a nursing facility so they can be fed, or they have to have a feeding tube in. It can be a really major issue just to have something like this happen. So when you're out in the field or you're seeing somebody that's fallen, I would advocate that you put the C-collar on. I know we're kind of against it in general, but I think initially, before the workup's done, a C-collar is not a bad idea. And then I would image anybody who even has a chance of having hit their head. Okay, chest. So rib fractures we talked about a little bit already. This is something that I see missed a lot, particularly with medical, like internal medicine professionals. People underestimate what a big deal rib fractures are in elderly patients. And the trauma data is really conclusive that with each additional rib fracture you add, the risk of that person dying goes up significantly. And as I mentioned before, it's super easy now that you have frail bones and decreased chest wall compliance and everything else to fall over and break ribs. If we have someone that comes in with more than 3 rib fractures, they're going straight to the ICU in our facility. And what's terrifying is when you see someone in clinic who their primary care physician ordered a chest x-ray and found rib fractures, and they just sent them home with some pain medicine in a 75-year-old, that person has an extremely high risk of dying. So if you're seeing someone in the EMS capabilities, for example, and they're complaining of chest pain after they fell, they have got to go to the hospital. They've got to. We observe patients with greater than 1 rib fracture, but we put them in the ICU if there's greater than 3. We're really aggressive with pain management. We use blocks. We're lucky to have fantastic anesthesia, and they put blocks, and that way we can avoid narcotics. But we actually put blocks in even a single rib fracture, particularly in the geriatric population. This can be a big problem for them. The problem mostly is that they don't take deep enough breaths because it hurts. Then they get pneumonia, they end up intubated, and we're sort of in a spiral there. Okay, musculoskeletal. So pelvic fractures are probably the most common. This doesn't include hip fractures, which technically is also sort of a trauma. You've all seen geriatric hip fracture patients. They've been in every ED in Cuyahoga County, of course. And it's super common for them as well to fall, break a hip, and everything's different after that point. But we're talking about pelvic fractures here. Pelvic fractures, very common, increases morbidity and hemorrhage significantly. There's been several, I can think of 2 incidences in the Fairview ER in the last 5 years where an elderly person fell. They weren't activated as a trauma. Everybody thought they were fine until they coded because they had a pelvic fracture that was bleeding the whole time. They should be considered unstable until proven otherwise in a geriatric population with a pelvic fracture. Other common sites of fractures, basically any long bone. It's very easy to break anything if you're an older, frail person. Okay, skins and burns. I'm not a burn expert, but burns can be very lethal in geriatric patients, extremely lethal. So we want to take these very seriously. But what happens a lot that we see, at least in our facility as a level 2 trauma center, is the hematomas. So you can get unbelievable looking hematomas in someone that falls on an anticoagulant. I mean, just huge bumps. The skin looks like it's about to fall off because the hematoma is so big underneath. They can shear off the top layer of their skin such that the skin doesn't have any blood flow. That's called a Morel-Lavillei lesion. They're very high risk for that. And that's another reason why people on anticoagulants often should come to the hospital even after minor falls, because that hematoma is not going to happen immediately. You know, if you're to their house or to their nursing facility within a couple minutes, you might not see the hematoma. But we definitely are going to see it a couple of hours later. Sometimes we have to take these people to the operating room. Sometimes we have to get interventional radiology involved. There can be active, brisk bleeding from a skin bleeder or a muscle bleeder that ends up causing a major issue in somebody. And then a geriatric patient can't walk because their hematoma is so big and it hurts so bad. And you can imagine what happens to a frail patient who now can't walk. Now we're in a nursing home, probably forever. And it's a whole spiral. So this is the second case study I kind of want to talk about, and this is an 89-year-old female who presented after a fall, anticoagulated, of course, for a recent cardiac stent. There's an extremely large hematoma on the right gluteal area. The CT scan shows a 25 by 30 centimeter hematoma, so it's like this. And all she did was fall, like nothing major. There are no current skin changes. So what would we do for this? This is, I think, one of the hardest things for me in my trauma decision making. What do you do with this? If I open this up, she could exsanguinate from that because she's still bleeding. And to some extent, the skin is providing some level of control of that bleeding. But if I don't open it up and drain it, that probably will never get reabsorbed. She probably won't be able to walk. It could change her life forever because I didn't drain it. So you're kind of running this like, what do we do with it? So usually what we do with it in our facility is we correct the anticoagulation. We consider if interventional radiology is going to make a difference. We wrap it pretty tight and see if it will stop bleeding. Once we're sure that it stopped bleeding, in a day or two, we often drain these, but not always. Even with minor trauma, 17% of geriatric patients will have a major functional decline as a result. And what that means is if you were living on your own before, you're probably not after you had a traumatic event. You're either living in a nursing facility, you're moving in with a family member, you might go to rehab for a little bit if you're lucky, but a significant portion of geriatric trauma patients are not going back to life as they knew it after they have a traumatic event. 60% of patients are discharged to a SNF, an LTAC, or rehab after a geriatric trauma event. So after something as simple as tripping over your cat or getting a little bit dizzy and falling when you're going to the bathroom in the evening will cause you to have a significant change in your lifestyle. So overall, my conclusions here, obviously we're all going to see a lot more of this. It's not the most exciting of topics, definitely the not most glamorous of topics, but something that we really need to pay close attention to. Make sure we bring them to the emergency department when we can, and to be aggressive about thinking about what their injuries could be. Thank you.
Just a couple of quick questions. There were several questions. You touched on blood thinners with transporting patients. The question that many of these lean towards is aspirin as big a concern?
Aspirin is not, and actually Plavix is not technically considered a blood thinner for our purposes in the trauma world. What I'm talking about is Coumadin, Brilinta, Eliquis, Xarelto, the big, full blood thinners. Not the antiplatelets, but the full blood thinners are the ones we're the most worried about.
And also the use of vacuum mattresses versus backboards. Are we seeing improvement in outcomes?
I don't know the answer to that.
What was the question again?
Whether there's a difference between vacuum mattresses and backboards.
Oh, I don't think there's.
I
don't know. I don't know if there's data. If our EMS audience actually has that data, I don't know.
Okay. And then one other, there were several questions referring to nursing homes and unnecessary transports of elderly. Is that an issue?
I mean, it's an issue for sure. I think that what we spoke about before with over triage, we're all trying to over triage. We're all trying to be as careful as possible so that we don't miss. But when you over triage, you are overutilizing resources. You are. And so I'm sure all of you feel that. And I don't have a great answer for how to minimize that, to be honest.
Just one question. One, gravity sucks.
Yeah.
Yeah. But one question, and that's being in that age group. It's I'm actually depressed now.
Thank you.
But reversal.
Reversal of anticoagulant.
Yeah, reversal, especially if patient goes to a non-trauma center or is evaluated in a non-trauma center and has to be transferred, or a level 3 being transferred to level 1.
Yeah. So obviously, if somebody has a significant bleeding issue, head injuries are the biggest one. But if you're in a motor vehicle crash or you get hit while you're crossing the road and you're geriatric and you've got significant bleeding going on, pelvic fractures, whatever, the sooner we can reverse anticoagulation, the better. Now, some of them are easier to reverse than others. Coumadin, you can give FFP, you can give vitamin K. There's any emergency department has that. The other ones are harder to reverse. FEBA is the one that we use at CCF. Mm-hmm. It's basically a KCC derivative. Those are extremely expensive, and I don't know that every ER in the world has access to them. But if you do, you should reverse people as soon as possible.
Well, thank you for that messaging. Okay, thank you. I would like to thank Kathy. Thank you very much. That's very good.